Hello everyone, I am going to show another interesting case. This patient is a 45 years old female. She presented with pain lower abdomen and the ultrasound showed a large hydrosalpinx occupying the pelvis on either side. The patient was symptomatic. So after the Gynec consultation, it was decided to go for bilateral salpingectomy. So main thing is whenever you are doing any pelvic procedure, you have to keep the patient in nice head down tilt. The exposure is very important. Make sure that all the bowel loops are moving away from the pelvis. And second thing is you have to catheterize the bladder. Third thing, you have to work as close to the cyst or hydrosalpinx as possible so that you will not be injuring any vital structures like ureter. So always work on the cyst wall. And this is a bipolar instrument which is used to seal and cut. Whenever you come across any major vessels or a larger diameter vessels, we have to use either vessel sealing device or a harmonic scalpel so that there will not be any bleeding in the postoperative period. So here I can appreciate we are using harmonic scalpel to divide the blood supply to the hydrosalpinx. On the right side, we have almost completed the procedure, and you can see we are actually working on the lateral pelvic wall where the vital organs like ureter lies. So you have to be very careful. Always catch the hydrosalpinx and try to bring it more medially so that you'll get a cleavage between the cyst and the surrounding structures, and we can nicely remove without any complications. After completing the right side hydrosalpinx removal, we are coming back to the left side. You can appreciate there is a bit of adhesions between the appendices epiploicae of the sigmoid colon and the hydrosalpinx itself, which is carefully released so that the sigmoid colon will fall away from the hydrosalpinx. Again, whenever you are doing any division like this, you stay on the cyst wall so that the colon will not get injured. So always stay on the cyst wall, and the plane is on the wall, so you should always follow the plane. You can appreciate the round ligament which is coming into view, and now we are releasing the sigmoid colon, and we are making sure that the colon moves away from the cyst. Then once it is done, then we are shifting the hydrosalpinx more medially and trying to work on the hydrosalpinx, and you can see the harmonic is used, and the harmonic active blade is kept away from the cyst wall so that it will not puncture the cyst. If you keep the cyst without puncturing, the plane identification will be very easy. Once it is punctured, then the cyst will get collapsed, hydrosalpinx will get collapsed, and it is difficult to follow the plane. So try to keep the fluid within the hydrosalpinx as much as possible, and try to work on the cyst so that there will not be any mishap like injury to the ureter. That is the only structure and important structure which we are worried about it. So one side always you see the cyst wall, and the other side you can carefully release the vital structure from the cyst. So this is basically a traction and counter traction approach. So give a nice medial traction to the cyst and a lateral traction with instrument that helps in identifying the proper plane. So after releasing the lateral aspect of the cyst, then we are going down, and you can see the ovarian tissue is also coming into view. So that is the infundibulopelvic ligament. So again the same principle, staying on the cyst and working close to the cyst. So in this case, we are going to seal the infundibulopelvic ligament also. This is again a bipolar device which we are using to seal the vessels, and we are sealing at multiple places. before actually dividing it. So this has got a coagulation as well as division property, this instrument. So the instrument is used carefully. So after sealing at multiple places, we are dividing it with the usage of harmonic shears. And almost the medial aspect is getting freed. That is the hydrosalpinx on the right side and the ovary on the left side. So the cyst is freed from the left ovary and we have kept it aside. And now we are sealing the infundibulopelvic ligament further and removing the ovary. This patient had undergone hysterectomy already and 45 years old female. So the oopherectomy is done along with the removal of the hydrosalpinx. So this is a combination of energy source, a bipolar, along with harmonic, which helps in preventing any blood loss. Again, you see, we are working on the cyst. Make sure this is the important step. Always stay on the cyst wall and never go to the lateral pelvic wall. So you got the iliac vessels as well as ureter, which is lying on the medial wall. So once the cyst is completely dissected out, we are actually opening the cyst and letting out the fluid. The fluid is sucked so that the size of the cyst will come down and it is very easy to extract it without actually enlarging the port site. So we can change 10 mm telescope into a 5 mm telescope, and the 5 mm telescope is used through the lateral port, and we are inserting the specimen into an endo bag, and the same will be delivered out through the 10 mm trocar port, which is there in the umbilicus. So this is the specimen extraction, and final hemostasis was very nice. There is no bleeding. Absolutely, the pelvis is free. Thank you very much.